So now we are live. Greetings, everybody. Here from Barcelona Rhinology School. We are with my friend Gwijde. It's correctly pronounced.
Very good, thanks.
Adriaensen. He's an expert rhinology from AMC Amsterdam, and he kindly accepted to delight us with his experience in FESS surgery in chronic rhinosinusitis without nasal polyps. So, with no further delay, Gwijde.
I'll share my slides.
Yes, exactly.
Is that visible?
Yes, perfect.
Great. So, once again, Cristobal, thank you very much for inviting me to deliver this webinar in the Barcelona Rhinology School. It's an honor, and I'm pleased. And, well, actually, I think doing a webinar now and then is a good way to stay in contact with foreign colleagues. Although I must say, personally, I miss the physical hugs.
Yeah. And the drinks.
Yes. So, but you provided this topic, surgery in chronic rhinosinusitis without nasal polyps. And it can actually be really challenging. Not that the surgery is so difficult, but when to do the surgery in this population. It's not so straightforward. And I think when considering surgery, at a certain point in treating a CRS patient, you think, let's do surgery. And that's always preceded by a why. What's the cause? Why did you start thinking about performing surgery? And also followed by a why. What do you try to reach with surgery? And then you really have to think about these two whys and define them. And then ideally, these two provide the how. So what you want to achieve with the surgery and how you perform the surgery. And those two blocks are something I will try to, well, give my opinions about, shed some light on too. And we'll see how that goes. So starting with the when, in chronic rhinosinusitis, the dogma always has been, when do you think about surgery? After appropriate medical therapy fails to cure the patient from its symptoms. And then you do the surgery. Why? Well, to restore access to local therapy, restore sinus ventilation, in order to restore symptom improvement in the patient. The how, finally, is by optimizing drainage and removing irreversibly damaged mucosa. Now, this has been the idea for very long, but you also see that appropriate medical therapy, what is appropriate, and restoring, when have you restored something? Optimizing drainage, when is the drainage optimal? How do you decide what is irreversibly damaged mucosa? This all is a little vague, and probably that's also why there is a lot of intersurgeon variability. But if you try to sort of make it more clear, maybe we can try to have a little less intersurgeon variability. Also the term, for example, CRS without nasal polyps, it's not really an entity. What it says is that it's everything that is not CRS with nasal polyps. So it's sort of an umbrella term. It's a heterogeneous group of people, and they probably need heterogeneous indications for surgery. So in that respect, I think it's really important or useful to pay some attention to the new classification of CRS that is proposed by the new EPUS 2020 document. And I would like to go through that with respect to surgery. So first, a little on this classification. What they first do is they divide chronic rhinosinusitis in two groups, primary and secondary. Then the division afterwards is based on anatomical distribution, locally or diffuse, followed by an endotype division to eventually have this specific phenotypes matched to all these categories. So for example, the first one is the primary versus secondary division. And the idea here is to realize, is there an underlying disease leading to or exacerbating the chronic rhinosinusitis? For example, in this girl, if she has pain in her eye, it's probably secondary, and we're not talking about a primary headache syndrome. The next division is the anatomic distribution. And anatomic distribution is localized or diffuse. So primary localized or primary diffuse, secondary localized or secondary diffuse. And then diffuse is not necessarily a pansinusitis. It can also be a little bit sphenoid left, frontal right, maxillary left, ethmoid right. It's just both sides involved in the disease or just unilaterally focally. Next division, at least in primary CRS, goes into endotype dominance, specifically type 2 versus non-type 2. So the eosinophilic IgE-driven, IL-4, 5-13-driven versus the non-type 2. And in the secondary, the endotype dominance is local pathology in the localized CRS and mechanical inflammatory or immunity related in the diffuse secondary CRS. Eventually, you end up with this schematic with several examples of endotypes. For example, the locally primary type 2, you go into allergic fungal rhinosinusitis. Diffuse primary type 2, the CRS with nasal polyps, which we encounter a lot, or the non-type 2, the CRS without nasal polyps, or at least a form of it. Secondary, local pathology, you have the odontogenic or the fungal bowl. And if you talk about diffuse secondary CRS, you can talk about a mechanical endotype, for example, cystic fibrosis, an inflammatory endotype, for example, Wegener or sarcoidosis, or immunity related if there are certain specific immunodeficiencies in place. Now, this already, I think, really helps in differentiating this whole group of CRS into a diagnostically specific subcategories, which help you in your treatment plan. But it can also help in the management, for example, in when to do surgery, yes or no. And you see the two green circles I provided. For example, both localized categories, you will probably end up with doing surgery in these specific situations. And looking at, for example, the whole secondary CRS schematic, probably you need to do a whole lot of diagnostical workup or even treatment of underlying disease before you even consider surgery. So it really already helps you into do what treatment when. So if you count these out, you're left with CRS without nasal polyps. At least there are several examples, but the red one, the non-type 2, non-eosinophilic CRS, primary diffuse, is probably the one that is a little bit tricky with respect to surgery. And that's probably the one that you had in mind when talking about CRS without nasal polyps. So I'll talk a little bit further on that one, if that's okay. Before to do so, however, a tiny thing about the primary localized non-type 2 CRS, the isolated sinusitis without nasal polyps. We know that often facial pain is an important symptom in this kind of CRS without nasal polyps. And I would just like to stress that it's really important to realize that pain in this disease entity ideally is not episodically, no attacks. And you should try to search for a correlation with the intensity together with upper respiratory tract infections or ARS. This is really crucial. If the pain is attack-wise or it does not have any influence whether you have a cold or not, it's probably not pain related to an isolated sinusitis. So then the primary diffuse non-type 2 CRS. I'd like to say something about what is appropriate medical therapy, then get a little bit into the extent of surgery, and tell a little bit about primary versus revision surgery. And then we sort of have the when and the why complete. Appropriate medical therapy. What is that? Of course, that's the whole problem. When is it enough and when is it good enough to decide to go on to surgery? Well, if there is already a little bit of evidence for the use of antibiotics in CRS, it's probably in this field, so in the field of the CRS without nasal polyps. And then definition-wise, short-term would be anything under 4 weeks. And the primary idea behind that is to combat bacterial infection. Whether a long-term has a different idea behind it, you also try to achieve some immunomodulation, maybe some anti-IL-8 workings, and it should be more than 4 weeks at least. Also, I think in appropriate medical therapy, it's very important to mention treatable traits. People who smoke, people who have allergy, people who have asthma, who have occupational exposure of stuff in the air that's very bad for the airways, air pollution, alcohol use, medication. All these treatable traits are called treatable for a reason. They need to be treated first in order to see what the effect is on the CRS. And I think it's best to do that first before you consider surgery. It's often looked over or not pursued strongly enough. Also, and just a little bit here, if you look at the new workflow of treatment schedule, this is a snippet from the EPOS document. You can actually see, maybe you can see my arrow. This is the primary diffuse CRS, and this is the non-type 2. There's appropriate medical therapy here, nasal rinses, saline, consider steroids. There's a whole lot of treatable traits, workup, but no antibiotics. Up until here, maybe antibiotics are considered or a FESS, and then if that doesn't work, maybe again long-term antibiotics are considered. So just to mention, that's not one of the first things to do. And if, probably try long-term. Then the next point is about extent of surgery. Also a little bit, again, definition forming. Full FESS we call full house FESS or whatever. We like to call it full FESS now, complete sinus opening. It's anterior posterior ethmoidectomy, middle meatal astrostomy, sphenoid opening, and opening the frontal sinus up to the draft 2A. If you go beyond draft 3, we call it extended, but we also include beyond borders of the skull base or the orbit is extended FESS. And then you also have the radical FESS, where you also remove significant amounts of mucosa. So that will be things like the reboot surgery. Evidence so far is not there to suggest reboot surgery as a useful mode of treatment in CRS without nasal polyps. Then what is a functional endoscopic sinus surgery in this category of patients? Well, there are a couple of things that we think you should achieve in order to have a functionally appropriate endoscopic sinus surgery. You need to create a cavity that incorporates the natural ostium. So connect accessory ostia. It should allow adequate, but there you go again, what's adequate? Sinus ventilation, facilitates mucociliary clearance, and facilitates, and that's very important, the installation of topical therapies. We're not curing the disease. We're trying to open up the sinuses for topical therapy. So how to do that? surgery in primary diffuse non-type 2, when to do what. And then specifically, I would like to mention this for frontal sinus surgery. Once you decide to do surgery, and maybe you start with a primary FESS first, if it doesn't work or there's significant pathology in the frontal sinus, you progress to a draft 2A. But if you have done a proper draft 2A and there's no iatrogenic leftovers to be gotten rid of, I think there's no place for a draft 2B in CRS without nasal polyps. And either you revise the draft 2A properly or you perform a nice and safe draft 3. So no 2B. A little bit concerning the surgery itself, to give you some markers of when to perform and especially when not to perform. What is this trial of appropriate primary medical therapy? Well, of course, it's saline rinsing and local steroids, and we like to use the local steroids in our saline so that you make sort of a medical mix with which you rinse. It's very important to check the compliance of the patient, because it works, but not if the patient doesn't use it. So what we often do is we give, for example, Flixonase Nizoles for 3 months, send the patient away, comes back, and then you ask, how much have you got left? And the patient says, oh, I have more than enough. Then you know the compliance is not very good. And you should really have the patient work with you, because, again, surgery is not curing. And the trial of at least long-term macrolides. Another point is that probably the preoperative symptom score, for example, the SNOT-22, is the best predictor for success in FESS, which basically says that you should operate on symptomatic patients, of course. But also if you look at social support, other clinical measures taken, or all these things, they do not really predict success as well as the preoperative symptom score. Also, there's evidence that lengthy delays in refractory disease, so a disease that keeps on being very symptomatic even though you installed appropriate medical therapy, could be detrimental to the symptom improvement after surgery. But this is primarily from literature in CRS with nasal polyps, and it's not as well research in CRS without nasal polyps. And there's little research on a mixed group, and there it didn't really matter if there was a big delay before surgery. But still, once you fail, there's no need to stall your surgery. And in that respect, also in an attempt to get a little bit less of surgeon variability in what cases to operate and not, Rudnick tried to define appropriateness criteria in order to have the minimal set of data you should have in order to consider surgery. And for CRS without nasal polyps, they came to the conclusion that at least you should have a CT score of more than 1, which is a little. At least a trial of at least 2 months of topical steroids and some antibiotics in the form of a short course, culture-directed, or the prolonged course to work for the anti-inflammatory effect. Also, the post-treatment score, so before surgery but after appropriate medical therapy, should be at least 20 or more on the SNOT-22 scale. Of course, this is very at least, and not all patients who meet criteria should have this surgery, but at least if it doesn't have these criteria, don't operate. And afterwards, they retrospectively looked at a huge database and also realized that patients who were deemed inappropriate for surgical treatment according to these criteria actually did not have a lot of success or effect from the surgery. So it's minimal. Then another thing which we often think about is the septum deviation, because you do your FESS and it's there. Or you see the patient with CRS, but he has also got a septum deviation. what do you do? Well, actually, the literature around says that the adjunctive septoplasty is not a bad idea. It's a good idea. Only reasons to consider and actually do it are threefold. You always have to think by yourself, does this deviation that I see contribute to the nasal obstruction? So, for example, I'm sorry, somewhere my Siri just went online, so I have to pull it out. Septoplasty, what we're talking about. Excuse me for that. So, does the complaint of the patient does he say, yes, this side is much worse, and does it correlate with what you see in the nose? That's a significant nasal obstruction caused by a septum deviation. Or while your surgery, are you really bothered by the bend in the septum in order to reach the maxillary sinus? Or already do you realize when putting in your nasal packing that it's probably going to be difficult on that side to take out the nasal pack? Those are good reasons to do a septoplasty, and actually if you perform it, it looks like the SNOT scores do not only improve on the nasal obstruction domain, but also on other general domains. So it works even better than just correcting nasal obstruction. And then successful surgery. Yeah, what is successful surgery? Well, successful surgery actually is reduction of the patient's symptoms. And for that, you probably need PROMs. So patient-reported outcomes measures. So I can really advise to start using them before and after surgery if you haven't done so already. And one that's used a lot is the SNOT 22. Use one that is validated. And also important in this respect is the idea of the minimal clinically important difference you can calculate it. So the minimal difference in scoring that you have to do before the patient sort of notices a positive effect. Of course, the idea of success is in the symptoms. It used to be more in revision surgery, but actually it's not per se that if you at a certain point have to do a revision surgery, that your first surgery failed. The idea is to gain symptom control, and if you need 2 surgeries for that, might be a good idea. Also, you have to put these PROMs into a perspective of the individual symptoms of the patient. And yeah, just look at what the main symptom is of the patient, how heavy he scores that, and whether you are able to gain significant or enough improvement in that domain for your surgery to be successful. Revision surgery then, after your primary surgery. When to do that? That might be even more difficult to decide. You've done your first surgery, patient continues to have symptoms, you recheck all your treatable traits, check compliance, you go back into your phenotype, endotype. Did I miss something? Is it still a vasculitis going on, or is there something with the immunity not right with the patient? Or did you do surgery but you rescan and you see that actually you didn't do the job that you thought you had done, or you made some iatrogenic damage? Then when is it that you start thinking about revision surgery? It's just not clear. What is clear is that a previous history of multiple surgeries, or apparent pus or purulent crustae at the time of the surgery on the table, are negative predictors for your surgical success. So try, of course, not to operate too often, but try really with your local appropriate medical therapy to get the patient as well as you can before you put her on the table. And iatrogenic anatomically wise, there are a couple of factors that relate towards risk of revision surgery. And one of those is the anterior posterior diameter of the frontal recess. Some say less than 4 millimeters. Remaining cells obstructing drainage or blocking access to local therapy, of course. lateralization of the turbinate, residual unsnit process, adhesions, and stuff like that. But you can just look at them in the nose, basically. And also look at osteoneogenesis or neo-osteogenesis or reactive osteitis. If you see it a lot in CRS without nasal polyps on the scan, it's a poor prognostic factor, and it correlates well to length and severity of the disease. It doesn't say you should not operate at a certain point if it's necessary, but beware that it's very tough. And if a frontal recess is filled with neo-osteogenesis, a draft 2A might not be very easy, and you might consider immediately performing a draft 3. So, when to do that draft 3 after the 2A? We do it a lot more now than we used to do. And in, of course, the appropriate patient selection, it's a very efficient and safe procedure. And in CRS without nasal polyps, so I'm just talking about that difficult subgroup there, you can actually very well offer it after failure of a properly performed draft 2A. And of course, there are always exceptions. So that even though this patient down here does not have a properly performed draft 2A and some odontogenic problems on the right side, looking at the frontal like this with a mucocele in the left frontal sinus and a lot of osteitis and a narrow frontal beak, it's probably one of those cases where, of course, the patient has rhinological symptoms. You would consider to perform a draft 3 straight away. And here you see the scan of that patient, just to give a clinical example. Now, actually, Cristobal, can you hear me?
Yes, sure, I'm here.
Because this was the first part on when to consider surgery and how to get people to more uniformly consider surgery.
Yes.
This next part is something that I put behind on how I think you also can perform surgery, well, according to what it says, a landmark principle, so that also the way we do it is more uniform and we strive for better uniform results.
Perfect. This is what we want. What do you do?
Yeah. Okay.
Nice.
So this is very practical. Before, I think it's very important, and you need to consider all these things.
Exactly.
And this is very practical. So I'll continue with that now then.
Yes, sure. Perfect.
Good. Because the second part, of course, is the person is on the table and you start your surgery. Now, with all surgery, I don't have to tell anybody how important surgical anatomy is. But actually what you should do, in my opinion, is transform this anatomy into surgical steps of the procedure that you're performing and make a roadmap. Once you have this roadmap on how to do your surgery, you should divide this map into specific landmarks according to which you perform your surgical steps. So it's not anatomy, it's applied anatomy in a way that you find your landmarks that you can always find. So that basically every FESS for CRS becomes sort of the same in a safe and thorough way. And it's a landmark principle. So for example, for a full FESS, the roadmap would be, in my idea, first to create a drainage pathway to the nasopharynx, if it's not there, so all the blood can go away and it's not in your scope. Then locating and cleaning the maxillary sinus, then locating posterior skull base. And I like to teach a retrograde cleaning of the ethmoid, but it doesn't really matter as long as it's safe and it works for you. Then working the frontal recess and finishing with opening the sphenoid. This is the roadmap.
Nice.
I like the retrograde ethmoidectomy because of this, the angulation of the skull base. If you find it posteriorly first and work towards anteriorly, you already go into the nose with the scope, and I think there's less risk of hitting the skull base in an inappropriate way. And also, I like to do the sphenoid last because I think also in training, the paraseptal opening of the sphenoid is the safest. And once you've already performed your ethmoidectomy, it's a little bit easier to find the ostium because the whole ethmoid is not in the way if you push gently towards a superior turbinate. So the landmark principle is basically to only think about and work towards your consecutive landmarks on your roadmap, so that when you get lost in blood, cells, also polyps, but we're not talking about that, all you have to do is think, what was the last landmark I'm absolutely sure I found? Go back there and progress from there again and find your way again. That's a safe way to operate. And what I would like to do is talk about these landmarks for functional endoscopic sinus surgery without nasal polyps. So first thing is creating the drainage pathway to the nasopharynx. All you need is a septum, nasal floor, and inferior turbinate. And as long as you keep those three in your eyes, you don't venture into a middle turbinate tail, you don't go too far lateral or medial. It's very easy. You go all the way into the choana and you have your drainage to your nasopharynx. Very obvious. It's an easy start. Second step is locating the maxillary sinus. Now, the safest way to enter the maxillary sinus, of course, is farthest away from the orbit. So, if you have the orbit and you go inferiorly, down, you have to take care because eventually you get into the inferior turbinate. If you go anteriorly away from the orbit, you eventually hit the nasolacrimal duct and you can encounter anything there. Doesn't matter. Only those two landmarks are basically what you need. So, also these two images to explain. The black line there is your maxillary line or your endonasal projection of the nasolacrimal duct, which is your anterior border. And then the horizontal attachment, which you see right here of the inferior turbinate, that's your inferior border. Where these two cross, it's the safest way, and also where normally the natural ostium is situated, but it's the safest way to enter a maxillary sinus, furthest away from the orbit. So the landmarks for locating the maxillary sinus are only this and that. And they're almost always there. And then we're talking about the horizontal attachment of the inferior turbinate. You don't need a middle turbinate. When people start surgery and I ask, what do you look for? One of the first things they always say, the middle turbinate. It's not very important until halfway into your surgery. It's an important structure. And you should leave it and keep it intact. And it's a division between the anterior and posterior ethmoid. But in finding your way through these sinuses and opening them, if you need to, it's not very important. And you can do all maxillary surgery you need without even thinking for a second onto the middle turbinate. You need the inferior one, horizontal attachment, and the endonasal projection of the nasolacrimal duct. Then you find the entrance, and then you open it or you clean it, and you can also do that actually in a way where I think is the safest, which is from danger to safe. So you palpate the back wall of the maxillary sinus and then make a sort of nice scoop towards the floor and anteriorly to the nasolacrimal duct again. And the same up against orbital floor and back to nasolacrimal duct again. And with these two movements, you can clear out the whole maxillary sinus if necessary. Why do you do that? To find the orbital floor. Why do you find the orbital floor? To follow it onto the lamina papyracea, right posterior of the nasolacrimal duct. That's the joining point you need to find first, and then you progress into the ethmoid. So once you find the lamina papyracea at the right level, following the orbital floor, you progress towards, well, if you do a full ethmoidectomy, at least, the posterior skull base. Why first finding the posterior skull base? It's hard. If you go underneath, well, at least at first, you avoid getting into contact with any of these ethmoidal arteries. And there's no lateral lamella back there. So it's also safer in avoiding hitting the lateral lamella. How to do that? You need to cross it safely. So you found your lamina papyracea, your medial border. By then, it's important to find your middle turbinate, but only by then. Stay lateral to it, above the horizontal attachment of the middle turbinate. Follow the direction of the orbital floor, and you will find the anterior wall of the sphenoid. It's a very safe way. While doing it, just think of these blue terms, and in your head, you can actually perform the surgery in a very safe way. These are the landmarks for the posterior skull base. Once you find it, you retrograde, clean the ethmoid. You stay parallel to the medial orbital wall and parallel to the conchal plate, not directly on it, but clearing it out parallel in a manner like this, towards yourself, away from the skull base. And I think that's a safe way to do it. While cleaning, you palpate, you fracture, take out the bone and shave the soft tissue. And yes, what I wrote below is the way I like to do it. Once you use a shaver in the ethmoid and close to all these structures, first palpate, never palpate with the shaver, never shave areas where you have not been before. And once you palpate the surroundings, just be sure to stay within 0.5 millimeter of what you've palpated, and basically nothing can go wrong with the shaver. So the landmarks for cleaning the ethmoid is from skull base, medial orbital wall, conchal plate. Find your next part of skull base, medial orbital wall, conchal plate, or lateral lamella, all the way up until your frontal recess, at least if there is no free-running ethmoidal anterior artery. Then once you enter the frontal recess, it doesn't matter if you do it last or first or only. It's a totally different kind of surgery. So for example, where the ethmoidal surgery is working towards you and maybe a little more fracturing and taking out, you have to become very meticulous in the frontal recess. You have to become all of a sudden very obsessive compulsive, and you start pulling out small things. You break them, you see them, you take them out immediately. You don't push them back into the frontal sinus, but you gently take them out. Try to leave as much mucosa intact, or at least the region back wall frontal sinus into the skull base of the anterior skull base. That's sort of the gutter. If you try to leave at least that intact of mucosa and avoid circular wound, I think you have the greatest success of a patent draft 2A afterwards. So the most important aspect, landmark-wise, there is the posterior wall of the frontal sinus. Final step, opening sphenoid. Yeah, paraseptally, it's pretty straightforward. All you need is a middle turbinate, superior turbinate, coena, and find it and open it. So using only these landmarks, instead of being amazed by what this other surgeon has done in your nose, or it bleeds, or you're looking for a middle turbinate which has been reduced, or only focusing on these landmarks, I think really helps. And you can always find your way, and you can almost make every functional endoscopic sinus surgery, well, the same, of course, depending on which area you want to operate. So that was actually the second part of how to operate. And then I think I told everything I would like to tell you about this subject.
Perfect, amazing. That was a really nice talk. So I will put you. Take out your presentation mode.
Yeah.
Yes.
Like
That's
this.
better. Yeah. So that was a really nice presentation. You really simplify the surgery and
yeah.
I no, but I really like that you use really permanent, in a way, landmarks. You don't.
Yes, that's the whole idea. It doesn't matter how much surgery has been performed.
Exactly.
You can always find those.
Yes, and when you were explaining, I was realizing that maybe I didn't notice that, but when I do the surgery, when you have experience, you do it fast, no? But you always have those landmarks in your mind. So
Exactly.
you manage around the
And
nose
once
and
you
the
can
sinuses.
vocalize them,
Exactly.
very good for tuition, I think.
Yeah, exactly. It's really, really nice. I have a couple of questions for you from the first talk, and then maybe for the first talk, but the second. The first thing is, what do you use for the? You said that you use corticoids inside the nasal rinses.
Yeah.
So which mixture do you use?
It's a Flixonase nasulus. I'm not exactly sure. It's a small
Yeah, the
vials.
frictionless. Yes, exactly. Yes,
Yeah,
the drops.
the drops. Yeah, and
Yes,
you just use 2 of them in 250 cc's of NaCl saline,
yes.
and you mix it and you use that to rinse twice a
Nice.
day. That's sort of our basic therapy, and you can actually, if it works, sometimes increase the dosage a little bit. Not
Exactly.
too
Nice.
much, but if you have refractory disease and doesn't matter, and you think it works but not enough, you can put in 4 if you have to.
Yeah, nice. Yeah, I've been using that as well, and it in the last year, I think, year and a half, and they work really nice.
Yeah.
And
Also, if you are suspicious of biofilm formation, the
yeah,
stick,
exactly.
you can add xylitol even, and it works really well.
Yeah, I think regrettably here in Spain, I think we don't have access to xylitol just to put. But anyway,
In Holland, they have to. You can get it online.
nice. I will check if I can get it online here. Yeah, it's by Amazon or whatever. It's nice. The other question is, it's always everybody talks about macrolide therapy, but what is your scheme? What do you
There are
use?
several macrolides you can use.
Yes.
Cotrimoxazole, clarithromycine. Personally, I like Zitromax a lot, which is azithromycine,
Yes.
and because it works longer, so you can give the patient less tablets. And a major part of successful appropriate medical therapy is compliance.
Yeah.
Really is. And
Yeah,
that's
for
also
sure.
a major part why people in studies, for example, all of a sudden go much better, is
Exactly. Then
because
really, yeah.
then they use the medication the way they
Exactly.
should.
Yeah,
So,
you're
but
right.
azithromycine, Zitromax, is very easy. You give the first week 3 tablets, day 1, day 2, day 3, and that's
Okay.
I think 500 milligrams. And the rest of the week you're covered. And then from week 2, every other day, 250 milligrams. So 1 tablet each 2 days.
Nice.
And it's little, and it's easy for them to do.
Exactly.
At least 4 to 6 weeks, and then often I see them back. And if it goes a little bit better, I at least postpone until 3 months.
3 months. Okay. Nice.
Of course, with all these macrolides, you need to take care of comorbidities, especially some medication for blood pressure and heart.
Yeah, exactly. Yeah, and you also do it over 65 years old because of or you train it.
Well, yes.
Yeah,
Is the honest answer.
yeah. No. It's good to know. I'm a little bit afraid about using in elder people, but
Yeah. No, I agree. You really tell them what to take care of which complaints, and then
exactly.
once they have a little bit, you get them back. It really depends on how easily you can see your patient back, or how easily you can call them, or that you think they actually call you if they have a problem.
Exactly.
And
Nice.
Holland is a small country in that perspective.
Yeah, it's. Other thing is that you talk about septoplasty.
Yeah.
Do you do septoplasty before the procedure, like in a classic way, hemitraction, or you try to go direct?
I looked it up, so I studied the literature for this talk, and I'm going to do it probably more often than I did before.
Yeah.
But what I'm talking about is concurrent septoplasty, so during your FESS.
Yes, but
so you do a FESS and a septoplasty.
classic, or just go direct to the spare or whatever? Like, I'm usually, I have a spare, I just take it out and
Yeah, yeah.
yeah,
I
no,
used to just gently push it aside, and I could manage, and I thought it was okay. But if you look, well, it's not very much. But if you look at the available evidence, it actually works better than just improving nasal obstruction.
yeah, nice.
So yes, spurs for sure. But also, if the whole septum, especially anteriorly, if you have an anterior deviation and you
Yeah,
have a very narrow nasal valve, talking
yes,
about
yes,
rhinoplasty, then you probably notice, going back in your head, that if you leave that and you push it aside and push it aside during surgery, then often after surgery, that side has more often recurrence of pus, polyps, whatever, than the other side.
yeah, that's interesting. Yeah,
So I think also a classic hemitransfixion.
yeah,
I have done it, but not so much.
yeah,
Uh, but you can do it,
yeah. I mean,
and I think
only
it's a good
adds, I
idea
don't
to
know,
do it.
yeah, 20, half an
But
hour of
only
surgery. No?
if it gives complaints, if it's
Yeah,
really in your way of reaching something, not just to say, "Ooh, there's a little deviation, and let's do it." No, no, only
exactly.
if
No, no.
it's. But that's
Yeah,
with all this, it's very important, I think, to stress we treat symptoms. We don't do
yes,
endoscopic aesthetic work. Eh?
exactly. Yeah,
We
yeah, yeah.
only
You're right.
treat
Yeah, that's the
symptoms.
key issue. Yeah, yeah, for sure.
Yeah.
Another question. Sorry, I have a lot of questions. So,
Sure. No problem.
like the follow-up time, because it's always how long do you follow your patient? Because
Yeah.
specifically, it's difficult.
If they're happy, I'm happy.
Yeah,
No, in this patient category, I always tell them that healing takes about 6 weeks. So at least this first 6 weeks, they come back, you take out the tampons. In between, you see them once for debridement. I like to do it, or at least see how it heals, because I think in the 6 weeks, sometimes you can interfere with extra medical therapy. And then after
exactly.
6 weeks, it really depends. How long have you seen the patient before? And it really also depends on the specific diagnosis of your patient. It really helps, this new classification. An
Yeah,
isolated sinusitis that has healed, done.
it's fine. Perfect.
Chronic rhinosinusitis, which is difficult with the purulence and the pain primarily, and I instill them on a very tough local therapy. I like to see them at least until 1 year after surgery, also to make sure that they're compliant, and often longer.
Yeah, nice. Yeah, I do pretty much the same. Nice, perfect. And as for do you use pre-op treatment for this kind of patients?
Yeah, well, there's lots of literature, of course, on preoperative steroids, yes or no, and after. I like to try to get them as healthy as I can before surgery, ideally, the CRS without, because that really helps. If you do a draft away in an inflamed mucosa, oh, it doesn't feel good.
Yeah, yeah,
Um, but I don't standard give them a week of antibiotics or prednisone before. You just see how it goes. But yeah, often they're still on a little bit of long term, for example. Post-operatively, although I
yes,
know there's little evidence, I almost always give them some oral antibiotics, but that's
yeah, me
also
too.
because we
Yeah,
use packing, which is non-absorbable, and even though we use that as a depot of steroids and antibiotics locally, I'm
yep,
still a little bit, and I give them systemic as well.
yeah, me too, me too. The same, pretty much the same. So here we have a question from the audience.
Yes.
And Antonio is FESS lover. It's nice.
Fast lover. Very
It's.
nice.
I also have the same question. The first, do you use angulated optics for the flaps? And my question and Antonio's question is, do you use flaps for TRAF 3 procedure?
Okay, so the first question was?
angulated optics for reaching the frontal.
Yeah, well, I'm taught, and I like it still, to only use 30 degree.
Nice.
So I think you can do either 0 degree but 45 for the frontal, or for 30. And the nice thing about 30 is the field of view. Because 0 degree gives like I don't know, -15 to +15 or 25 or something.
Yeah.
30 degree gives a field of view up until 55, but also -5. So you can still look straight ahead with a 30 degree. And a 45 degree, you're unable to look straight ahead. So you already quickly need double angulated instruments if you use a 45 degree scope, and not with a 30 degree scope. And you can get, I never switch for 45 for a draft 3.
Yeah.
Really works well, and you just keep the scope and turn the endoscope. You can look at the maxillary and get straight to the floor of the sphenoid sinus if you have to. It's really nice.
Yeah.
Flaps in draft 3, no.
No, you don't use it.
Okay. No flaps, but we leave the tampon, yellow net or Lomatuelle or fatty gauze, 10 by 30. It's very long.
And you have to remove it afterwards, or it's reabsorbable?
We remove it in the outpatient clinic.
Okay.
We leave it for 2-3 weeks maybe. And it's very nice. No need for flaps.
Oh, nice.
So far.
Nice, great. So, Gwijde, I think we're almost 1 hour of talk. I know you're a father as me, and
yes,
it's late. So thank you, everybody. Thank you, Gwijde, for your time, for this amazing lecture. It's really nice and really practical, and all of those who are initiating in FESS surgery, please use this approach for the surgery, because it's really useful and you will never miss anything. So thank you very much.
So much. I enjoyed it a lot.
Yes.
Keep in touch.
So just a moment.
Sure.
So good evening, everybody. See you in the next episode.